Welcome to this week's edition of Good Books Radio. I'm Dr. W.F. Strong. I'm your host. Our book today is Shocked by David Casarett, Adventures in Bringing Back the Recently Dead. Before I get into the book, I do want to thank our sponsor, audiobooks.com, where your first book is free. Just go on the website, audiobooks.com, and register, and you get a free book, a free download, and you can listen anytime on any smartphone, on your Kindle, on your iPad, on your computer, in your car. Any place that you have Bluetooth, you can access it, and it's a really good way to experience the fine books that we all love. Our book today, again, is Shocked, Adventures in Bringing Back the Recently Dead by David Casarett. He is a physician, he is a researcher, he is a tenured professor at the University of Pennsylvania Perelman School of Medicine, and his studies have been published in the American Medical Association and in the New England Journal of Medicine. He's written a book in which he's interested in how medicine brings back the recently dead, how we revive those that we believe are gone, and the miracles we have witnessed in bringing back those that we thought were beyond our reach. So let's go to the phone now and talk with Dr. Casarett. My first question for you, Dr. Casarett, is when you pronounce someone dead, is it a fact or is it a matter of opinion?
I was hoping for more to that question. It depends on the circumstances. So in circumstances in which somebody is pronounced dead in an intensive care unit, we know exactly what's going on with that patient. We have a lot of lab tests and results. We are pronouncing pretty much a fact. Certainly when we make determinations of death based on brain death criteria, that's a fact buttressed by a lot of lab data. Keeping in mind there are always medical definitions of what we mean by death, but assuming we agree that death means cessation of heartbeat, respiration, no meaningful brain function, we can make those determinations with most of the weight of a fact. I think where things get tough is when physicians, paramedics, nurses need to make these decisions urgently without a lot of information. So somebody's heart has stopped beating. They were last awake and alert 15 minutes ago. No sign of a heartbeat. Is that person dead? Well, many people would say yes. Other people would say, well, I've brought people back like this, so let's give him another shock and let's try CPR for a few more minutes and see what happens. And sometimes those efforts are successful. So there's definitely a sliding scale of fact, if you want to think about it that way.
What do you think that the medical community in general, errs on the side of giving them every opportunity to come back?
I think overall that's probably true, but we also know that it varies. I mean, depending on what hospital you're in, what emergency room you visit, who's taking care of you, we know, for instance, that some physicians, just in emergency departments alone, will run a code when somebody has a cardiac arrest for 20 minutes. Others will do it for 30. Others will do it for 40. So I think, in general, physicians being physicians and medical folks being medical folks, we're trained to bring people back from the dead. We're trained to help people live longer. I'm a hospice doctor, but I remember back in medical school and residency, the focus of pretty much everything we learned and did was how to treat disease, how to cure disease, and how to make people live longer. So that's generally the default. That's our first impulse when we see somebody who's passed out, doesn't have a heartbeat, is to try to bring that person back.
Are there more effective, shall we say, pharmacokinetic opportunities than there were 20 years ago for bringing people back?
Sure. There are a lot of drugs that we have now in a typical CPR crash cart that weren't around, or at least weren't used a while ago, back when I was in medical school. And we're talking late 80s, early 90s, so it's not that long ago. We're not talking about the Middle Ages.
Right.
But a typical crash cart would include you give patients a shock, you try epinephrine, another shock, you try lidocaine, and after that you were sort of in experimental territory. Some crash carts had amiodarone, some had beryllium, believe it or not. But that was it. I think now there are certainly more drugs, antiarrhythmics, a lot more other techniques too, like cooling people. Something I spend a lot of time in the book talking about.
Yeah, that's fascinating. So with the cooling of people, that's a whole new perspective for, I'm sure, most of us. What does that do?
Well, interesting you should say that. It's a new perspective for a lot of us. It certainly was for me. As I said, I'm a hospice doctor, so a lot of this was a steep learning curve for me, learning about resuscitation. So that was surprising, both how much cooling and cold is part of resuscitation techniques, and how much of it is going on right now in hypothermia protocols for cardiac arrest, for instance. But it's actually not that new, so I really shouldn't have been that surprised. Even back in the 1700s, there was something that was known kind of ominously as the Russian method of reviving or at least restoring people who were drowning victims or cardiac arrest victims. People were buried in ice or snow, which, granted, doesn't make a whole lot of sense. You're basically adding the dangers of frostbite injury to whatever other problems you have going on. But the theory is sound, that if you are able to somehow trick the body's cells, and particularly brain cells, into a state of lower metabolism, where they're using less oxygen, then in theory at least, those cells, those brain cells in particular, can survive longer without injury under circumstances where there isn't a whole lot of oxygen around, like in the setting of a near drowning or a cardiac arrest, or in other circumstances like surgery, or circumstances when there's been a lot of blood loss, like in a battlefield injury. So even back in the 1700s, people were beginning to think that there might be some benefits to cold.
Well, actually, when I was reading your book, I was thinking of David Blaine's story about learning to hold his breath for 17 minutes underwater. And he said that the trick, so to speak, was to slow your metabolism, to just quit using so much oxygen. You had to reach that level of very low oxygen use in order to survive that long. Of course, the 17 minutes included oxygen loading before he tried it. And so it's quite an amazing feat. But he learned to slow his heart rate, and essentially he said he would be very cold, and so he could shut his metabolism down.
That's interesting. I hadn't thought about that parallel, but you're right. The analogy works, and that's the foundation of a lot of the work that's going on now, including a large clinical trial of trauma victims that's going on at the University of Pittsburgh to try to chill trauma victims down to very low temperatures, around 50 degrees, in hopes of reducing their metabolism and preserving as much brain function as possible. It's also the basis of a lot of the research that's going on now to try to induce a state of suspended animation in patients.
So is the idea somewhat like, sometimes they put people into an induced coma? Is it along that line of thinking that will just slow everything down and give their body a chance to catch up?
Yeah, I think that's a neat analogy. Induced comas generally are more neurologic, so the idea is that you put the brain into a state where it's not very active. And so this is sort of like that in a sense, only you're doing the same kind of thing for the entire body. So the sort of holy grail of suspended animation research is you come up with a magical drug that will all of a sudden induce every cell in your entire body at the same time to drop its metabolism by 95%. Not just the brain or not just the heart, but everything.
Something that you mentioned in the book that I found quite fascinating, at least the prospect of it, is the notion that now, when you die, that you can, instead of being cremated, instead of being buried, you can, sign yourself up for this company who will keep you in a kind of suspended animation for 200-300 years until they find a solution to your problem?
That's certainly the hope. There are plenty of people, actually, in the book I talk about visiting a conference put on by this company, the Alf-Core Life Extension Foundation. It's based in Scottsdale, Arizona, and I spent a weekend with a group of a couple hundred people who either had signed up for this program or were seriously thinking about it, willing to pay $70,000 to have their head cryopreserved in liquid nitrogen, or $200,000 is the current going rate to have your entire body preserved.
For how long? How long do they guarantee you that you'll be preserved?
Well, in theory, until they're able to revive you. It's a bit of a leap of faith in a lot of ways, thinking you might be able to get revived on the other end, despite the fact that, as far as I know, we've never managed to do that for a human being so far. And then trusting this foundation to take care of you, not just for a couple of years, but we're talking hundreds of years potentially. Somebody has to keep an eye on you, make sure that your tank of liquid nitrogen is filled up, and somebody's going to have to take charge of reviving you on the other end. So there's a lot of trust involved, and a lot of hope, and a lot of hopeful cryonauts.
Cryonauts, that's cool.
Are kind of jumping into that vat of liquid nitrogen and hoping for the best.
But when you think about it, what do you got to lose?
Well,
other than the money.
When I was at the conference, I met briefly with a woman named Kim Sozi who was diagnosed right out of college, I think, with a really nasty brain tumor called a glioblastoma. Went through all kinds of really, really aggressive treatment. And, I was chatting with her, and we were joking about the cost of $200,000 to be cryopreserved. And she said, look, I've spent, or my insurance company has spent $500,000 on cancer treatment, and that hasn't worked. So at least this is something new. And her argument also was, I know it's an experiment, but whenever you're an experiment, you kind of want to be in the treatment group, not in the control group. And that was really eye-opening to me, because I had kind of gone to this conference thinking it would be full of a lot of deluded people who were in denial about death. And certainly there were many of those people there. But other folks were saying, what have you got to lose? People are often paying for the costs of cryopreservation with life insurance, so it's not like they're spending their life savings on this. But they're going into it with their eyes wide open, knowing it's a real long shot, but thinking, I play the lottery every week, and that's, playing a really long game, so why not this?
Well, I don't see it as a crazy thing, really. It's I can see how people could see it as crazy, but if they put you in the ground, you're not going anywhere ever, unless, you're going to heaven, but I'm just saying your body in the time the earth is here, it's just going to rot, and you're not going to have any chance of being revived. And same thing, obviously, with cremation. So this is a very, very long shot, like you say, like bigger than probably the biggest lottery, but it is a shot. And the only thing you're giving up is the money that you might pass on to your relatives.
Right, which I think is not trivial. And I certainly talked to a couple of people whose story didn't make it into the book, but people whose decision to be cryopreserved really led to a lot of distress in the family that they were leaving behind. So it's not a trivial decision.
No, it's not.
But many people would tell me, right, it's a long shot, but a 1 in a million chance is mathematically better than a 0 in a million chance. So,
but what is it about the chopping the head off and preserving that I don't understand? They revive you, and you're going to be part of a robot, or what are you supposed to do? Yeah,
that's where things start getting a little bit unclear and a little bit weird. So there are a variety of different theories that get discussed, ranging from creating a clone of your body and implanting that brain with its memories into a cloned body. Other theoretical approaches, which are either more or less weird depending on your point of view, is using the somehow knowledge that's stored in your brain, uploading it to a computer, and basically creating a virtual clone of your personality and your memory. So you wouldn't actually wake up in a body, you would wake up in a computer interface. I'm not sure which one of those is stranger.
Well, actually, that would be a hell of a database for future anthropologists who wanted to, directly access real-world perceptions of a different time.
Right, especially for those first few days when somebody wakes up thinking that they're really in 2014, only to realize that they're off by 1,000 years.
That would be what I would call disorienting.
It certainly would, not to mention the fact that presumably all of your family and everybody you know is also dead unless they've signed up for the program along with you.
Yeah, there's a Mel Gibson movie where he is resurrected, and I forget the name of it, but he was only supposed to be out for 6 months, and then somehow the guy who was supposed to wake him up forgot about him or died, and then he wakes up and it's 50 years later, and so everybody he knows is dead. So it's a good movie though.
All right, I'll look for it.
I wish I could remember that, but Mel Gibson revival or something. I'm sure. I think it's about 20 years old. So it's worth a look. Now, what is the longest someone has gone and been revived? How long have they been allegedly dead or clinically dead and been revived? What's the record?
Well, again, we have to be careful about using terms like clinically dead, and I fall into that trap too, so I apologize for that. But clinically dead, you usually say no heartbeat, no respiration, no sign of brain function. And so most of the stories that we hear of amazing stories of survival, we don't have all that information. So we know no heartbeat, no breathing, but often don't have PET scans to do brain scans or caloric testing to check reflexes. Hard to do in the field as you're resuscitating somebody. The longest story that this is a constantly changing field, and I confess even now, after spending a year researching this, I may be sadly out of date, but certainly the best publicized long survival that I came across was the story I tell in the book of Michelle Funk, who was about 2.5 years old when she fell into a creek, was underwater, it seems, for about an hour, and spent another 2 hours without a heartbeat, without spontaneous respirations, and was brought back. That, for me, whether it's technically the world's record, I don't know, but that's kind of the bounds of what I came across in the other examples that I saw. And even today, that was back in the 80s, but even today, that's pretty impressive.
Well, as a doctor, what is your explanation for that? How is that possible?
Well, that's a really interesting question, and that's the question that many people ask when these amazing survival stories become revealed. There's initial flood of media attention, and everybody wants to interview the patient and the family, but then once that media attention dies down, then the scientists and researchers get involved, and they start asking, well, so what was the secret? Why did this young girl manage to survive after 3 hours? What did she do well? What went well? What went right? And there's some obvious things like the fact that she was young. In general, younger people without other health problems, young people with young brains survive better. But and there's nothing that you and I can do about that. We're far beyond 2.5 years, unfortunately. But there is something that we could learn that can and has actually helped other people, and that's cold. That the colder you are and the slower your metabolism is, the less oxygen you and your brain use, the better you do after a cardiac arrest, whether that's due to drowning or a gunshot wound or a battlefield injury. And in fact, a lot of the other stories of amazing survivals after cardiac arrest or especially near drowning are stories that occurred in the setting of extreme cold. And that's why near drowning are actually a good example of how resuscitation can work, because water generally is cold, often very cold.
Mm-hmm.
And so at the same time that somebody drowns, stops breathing, their heart stops beating, they're already beginning that process of being cooled, often to very, very low temperatures. And so it's stories like Michelle Funk's that made people realize there might be some substantial benefits to cold that we could then begin to figure out, harness, and use in protocols, for instance, that are up and running now, that use a combination of ice and chilled saline to cool people who have experienced a cardiac arrest.
Have you been involved yourself with attempting, that method of cooling someone?
No, I haven't. Because I'm a hospice doctor, I don't do a lot of resuscitation myself. Yeah. Most of my patients have already made their peace and decided they really want to focus on quality of life rather than quantity. But certainly back in medical school, was involved in a lot of resuscitation efforts. And then more recently, in the process of researching the book, I took rides with paramedics and watched them as they did their work, some of which involved trying to resuscitate patients using those protocols.
I loved your chapter about Amsterdam and the early history in Amsterdam of forming like emergency societies to try to save the drowning victims or revive them.
Yeah, that was really surprising to me, that a lot of what we do now in terms of resuscitation had a distant history back in the 1700s. Mm-hmm. Many of the techniques they tried we don't do anymore, like tickling the back of somebody's throat with a feather. Not much to recommend it. Throwing people over the back of a trotting horse, I actually tried that in researching the book. I wouldn't recommend that either. But other things, like using an endotracheal tube connected to bellows, it's kind of primitive, but it's really the original version of a ventilator that we use now for patients who can't breathe on their own. So, what was the idea behind blowing smoke up the anus? I mean, that was really crazy. Yeah, I thought you might bring that up. With most of these things, you look at them, or at least I looked at them and thought, what were they thinking? Right. The only thing I could imagine is that tobacco smoke contains nicotine, and nicotine has effects on cholinergic receptors and could, in theory, if it's absorbed, cause an increase in heart rate. That obviously wouldn't help if a patient is in asystole with no electrical activity, or even if they're in ventricular fibrillation. But if somebody had recently drowned and they weren't actually dead, their heart was beating, but they were just very, very bradycardic, you could see how maybe tobacco smoke in the right place at the right time might be a way of getting that heart rate up just a little bit. There are probably easier ways to do that. Yes. But and then they also rolled them on a barrel. That was actually popular. Yes, they did. That was actually popular in Amsterdam in the 1700s, although to their credit, actually, the Dutch Society in Amsterdam that kept meticulous records of successes and failures in resuscitation, after a time realized that it wasn't actually helpful and was potentially harmful, and tried to convince would-be rescuers that rolling over a barrel was not a good thing. Unfortunately, they had a hard time convincing people, because for a while the society had been saying it was the best treatment, and then when they started telling people, no, actually it doesn't work, nobody listened, and so they had a hard time actually stopping the barrel rolling. It's hard to break people from tradition and custom, isn't it? Exactly. Is there anything like that today that you know that people tend to do in emergency circumstances that is just wrong and harmful? Well, I don't know about wrong and harmful, but for a long time, the procedures for lay rescuer CPR, so people without training, included some things that really didn't work or weren't particularly helpful. So I remember taking CPR lessons 5-10 years ago, we were, as lay rescuers at least, told to check for breathing and check for a pulse. But it turns out that even with trained people with medical backgrounds in emergency settings, it's really hard to check for a pulse. So that's been dropped in some of the guidelines. The other big deletion in the most recent version of the American Heart Association guidelines has been the breathing part. For a long time, the process of CPR involved breathing for somebody and pushing on their chest, until people realized, first of all, that the breathing didn't help that much, because it's not efficient necessarily. And what really matters is CPR and defibrillation, getting that heart started as quickly as possible. So the breathing part of CPR has been dropped. The other reason, I think, my impression has been that it was dropped is sort of an ick factor, that some bystanders thought about performing CPR, but the whole idea of the mouth-to-mouth resuscitation scared them away. And so they could have helped a patient, but didn't. And so it was stories like that that made them think, well, maybe if we drop that breathing piece that doesn't really do much good anyway, we could get more people doing what's known as hands-only CPR.
How interesting. I wasn't aware of that. But I understand the ick factor, because I've heard people, mention such a thing. Oh, I don't know if I would do it to them, or, you're risking AIDS, or you're risking hepatitis C, or God knows what. Now Ebola, who knows? So a lot of worries. Well, here's my last question. What do you think will be the evolution of this? Well, let's say 100 years from now, do you think that they'll think of the resurrection time as an hour?
I think that's entirely possible, and potentially even longer. Whether that's scientifically based, it's hard to tell, but certainly stories like those of Michelle Funk, the girl who survived after 3 hours without a heartbeat.
That is incredible.
And as doctors are facing somebody in similar circumstances and they're thinking, do we stop or do we keep going, images like hers have to flash through their minds, and they've got to be thinking, well, I know it's a long shot, but let's just try an additional 5 minutes. And as they try a little bit harder, as they give people a little bit more time, they're going to have some successes. I think the real challenge is figuring out when too much is enough, or vice versa, so we can begin to understand not just what our likelihood is of bringing somebody back, but what the consequences are likely to be, and what shape people are going to come back in. But all of that, honestly, is getting better.
Well, I want you to, sometime when you get through with your book tour and have some moment that you can do this, look at David Blaine's TED Talk. It's a TED Med talk. And he talks about how he learned to hold his breath for 17 minutes. And, of course, I always thought, well, you can't possibly do it more than 6 minutes because you'll be brain dead. And he, of course, talks about all that. And he learned to purge the carbon dioxide and to load oxygen and to slow his heart rate. And that's how he was able to make the world record underwater. And so it fits a lot with what you talk about in this book. So there might be something there that you can benefit from. And it's a great little speech. It's a wonderful talk.
I will certainly look it up. Thanks for the tip.
Well, I love the book. I like books like this that are kind of on the cutting edge and a little bizarre, in the terms of talking to unusual people, like those that want to, the cryonauts, and didn't have that word before, but it's great to add it to my vocabulary. I don't know when I can work it in, but it's a great term.
Well, good luck with that.
Good luck with the book. It's a wonderful book. I'm sure it's going to be a big hit.
Thanks so much for talking.
Yes.
It was a pleasure. I enjoyed it.
Okay. Have a great day.
Thanks, you too.
The title of the book, again, is Shocked, Adventures in Bringing Back the Recently Dead by David Casarett, M.D. I think that you will find this a fascinating read. I certainly did. It is full of great little stories and anecdotes from the world of medicine. So pick it up today. I'm Dr. W.F. Strong, signing off for Good Books Radio.